Okay, thank you. And once again, hello everybody. Welcome to today's webinar. My name is Rob Wilder. I work for Spoke as a senior product manager. We're a participant in the IHE. I'm a planning committee co-chair for the patient care device program and a co-lead for the alert communication management working group at the IHE. I'll be your presenter today for this session of the 2020 Inside the IHE webinar series. Today's focus is going to be on patient care device interoperability. So the devices domain and its incorporated standards include interoperability of all types of connected patient health devices. The profiles for this domain address needs for collection of patient and device data, patient association to those devices, reporting of information about devices in the patient environment for documentation or event notification purposes as well. We also have a focus on storing the data where needed to ensure proper safety. So while some of the programs within this domain have been around for years, the devices domain itself was newly formed in 2019. This was driven by a joint effort that's ongoing right now between Personal Connected Health Alliance, or PCHA, as you might have heard of it, and the IHE International to further align our respective goals and our operations. These groups both had similar interests, and it made sense for us to combine forces to improve innovation while simplifying the pathways to interoperability for any interested parties looking to pursue those. Examples of those similar interests would include enabling interoperability between the consumer devices, think of your Fitbit, and remote patient care devices or other health information systems. And addressing common challenges in achieving widespread adoption of those jointly developed standards. We also wanted to look toward unification of the rest of the programs used to validate those profiles. So the goal of this new domain, to summarize, is unifying our approaches to interoperability and more easily share ideas across the folks that develop these types of solutions. The domain itself now includes 3 programs. The Patient Care Device Program, which formerly was called the PCD domain, is concerned with use cases in which at least one actor is a patient-centric point-of-care medical device information system. That communicates clinical information system information to other systems or alternatively to people. The PCH program was newly formed in 2019 to guide development, implementation, and conformance assessment of profiles connected with those healthcare devices, mainly focused on personal healthcare devices. And this includes personal healthcare applications to manage measurements of personal health metrics and make them available to health information systems and exchanges globally. The first profiles of this group were published this year in 2020, April, and more information about that is going to be coming in another IHE webinar series presentation that we're going to do. The third program is the Device Point of Care Integration Program, and that has a focus on device connectivity around the patient-centric point of care. So that includes device discovery and association, data reporting or symmetric bidirectional communication, and external controls of those devices as well. Now, given the combination of these groups is recent, for this year, we're going to have multiple presentations covering these programs within the domain. In the interest of time, today's presentation is going to be focused more specifically on the Patient Care Devices program. So a little bit more information on the PCD program, as we call it, formerly known as the PCD domain. It traces its origins back to 2001, actually, but we've been around more formally since 2005 with PCD. PCD was formed to address point-of-care integration needs, with its first profiles being developed in 2006. The effort was initially defined to utilize open standards that would enable interoperable solutions and drive out-of-the-box type patient care device integrations. These standards can be used to easily implement and manage multiple systems within a healthcare enterprise. We can increase the return on investment with connected systems as well and greatly diminish the cost of ownership for those systems if they're implementing the standards out in the field. The first release of the technical framework, as we call it for PCD, that final text occurred in 2011, and it's been grown consistently since that time. So looking at what we implement with, most of our standards are PCD based on HL7, with some focused areas more recently starting to move toward FHIR. We'll cover that later in the presentation. The dominant HL7 standard that we use in this program is version 2.6, with some incidental usages of 2.7 and 2.8. It's also important to note internationally that some lower levels of HL7 versions have been used as well to satisfy regional conformance requirements. The PCD profile uses also, as we got listed here, IHE 11073 standards, and we'll reference that at different points during this presentation. Now, our use of IHE standards is really intended, among other things, to harmonize nomenclature, enumerations, and units of measure to conform with industry requirements. Output transmissions, something important to note, that's also included as part of our profiles. But these, of course, by nature, they're not HL7. For these systems, in order to make sure we're still conforming to standards, we needed a mature standard that was based on communications. So the PCD domain conforms to the Wireless Communication Transport Protocol, or WCTP, as it's named out in the industry, for an industry standard communication method. And this profile was chosen for a few reasons. It fit the bill of maturity in the market and had a bidirectional capability, the qualities that we needed for PCD profiles to work. It was broadly accepted and established as a standard already in healthcare before we chose it, and it was extensible. This protocol can and has been easily extended to serve the needs of IHE profiles when we've needed it. PCD uses other IHE domains when necessary as well, such as the consistent time measurement profile contained within the ITI domain, and that'll be covered more there. We couldn't exist, of course, without the generous contributions from our co-sponsors. HIMSS, of course, the American College of Clinical Engineering is involved, and the Association for the Advancement of Medical Instrumentation as well. The PCD program includes a number of profiles I'm going to cover here today. These are all listed here along with their overarching purpose. As you can see here, the profiles cover a wide area of interoperability for devices, including association to patients, getting data collected from the patients for the health record, and ensuring updates or alerts are properly communicated as well. As we go through these, I'll cover some supportive efforts of the profiles that ensure conformance to existing partnered standards. And these profiles, it's important to note, since they help PCD profiles be more universally conformant in live healthcare environments. It also highlights the evidence of cross-domain coordination and planning, cross-pollination of profiles that's really common within the IHE and something that drives our solutions forward. All right, so now let's talk in more detail about some of these profiles within the domain. DEC, or Device Enterprise Communications, was the first profile launched in the PCD program, so it's only appropriate we'll go for that one first. This profile is focused on updates of patient vitals information to the clinical information systems or other records-keeping systems that are going to need to store it. This profile has three distinct actors. The Device Observation Reporter, or DOR as we call it, is the sending system in a transaction that's collecting information from the device and translating it to be sent up to the record. The Device Observation Consumer, which is the record or other healthcare system that's going to consume that data. And the Device Observation Filter, which is an optional component, that's injected to provide an ability to filter floods of information that may be delivered from some types of healthcare devices. So how do we use this profile? If a device has an observation of a patient vital that needs to be put into the patient's medical record for use in decision-making, research, things of that nature, this profile provides a common way of getting that information from the devices to one or many storage applications that would need to consume it. This enables the device or the device system that's collecting the data to efficiently share that information about the patient's record for records keeping. In each of the profiles, there's a series of transactions used. All of the PCD domain profile messages, for instance, start with PCD, followed by a number to associate their purpose. Within this profile, for instance, you can see PCD01 is the source message that's being sent out from the DOR, and PCD02 is the response being sent back to the sender. RDQ, or retrospective data query, is another one we have. RDQ is a profile that can enhance the use of supported device enterprise communications actors, so the DOC, the DOR. If the data being captured from patient care devices was only sent for storage using the DEC profile, it wouldn't really be able to be called back by external applications when some use cases call for it. So scenarios where data callback is needed, PCD provides this RDQ profile, which allows for data that was stored in the central server to be called back for use in specific time, or we use specific time or patient parameters to be able to collect that information accurately. Now, as you can see here, we're maintaining the typical PCD nomenclature of PCD 12 and PCD 13 for the request message and the response message accordingly. As you can see here, this will only allow systems to capture detailed information that can drive more context into their clinical applications with information about the patient's current or historical status, depending on the call. Our next profile in the PCD program is ACM, or Alert Communication Management. Now, if a device has an alert that needs to be addressed in this profile, this is the one that's used. It includes any alerts that require notifications from the patient care device, including patient-level alarms that need to be delivered immediately to a clinician. Workflow step notifications can be incorporated, or advisory events about the device condition or status can be sent as well. This profile has three primary actors. The alert reporter detects and synthesizes and generates the notification based on the patient conditions. This is typically the device system itself. The alert manager, which receives alert notifications from the AR in near real time, then filters and directs notification based on the content in that message. The AM uses its own configurations from that point to extract information from the message and then determine what staff roles, groups, individuals, or et cetera should be receiving a notice of that communication. The alert communicator is the endpoint device. It is responsible for receiving and displaying the notification of the event from the recipient or to the recipient, while providing means of response from the recipient of workflow purposes. Workflow responses from clinicians can be passed to the AM actor for further workflow steps to take place based on that feedback, then sent back to the AR actor as well if required. So let's talk about some of the message types used here. So within this profile is a PCD04 source message that originates from the AR. It's qualified and then generated by the AR actor and sent to the AM actor. The AM actor receives the PCD04 message. It executes filtering on that event and decides who to route the notification to. Now, once the AM actor identifies the right recipients, a PCD06 message is sent, and this is our first taste of the WCTP protocol we talked about earlier for personal healthcare communications devices. And that's delivered to the AC actor on the device for the clinician's carry. The AC actor can then provide status updates based on feedback from the recipient carrying that device. The AM can then use that for alert escalations, reporting, or logging. This response coming back to the AM is called a PCD07 message. Also, from an optional perspective, if a PCD07 message is passed to the AM, it can generate a PCD05 response. This is another message that goes back to the AR, and this allows for response status updates to be sent to that originating system if it's needed for reporting, logging, feature, workflow support, really anything that the AR wants to be able to use that response data for. While PCD05, it's important to note, it is a response. It's not a replacement for an HL7 ACK. Really, all of our responses are for the ability to provide status updates to the source system for an ongoing alert or to close the loop on one, not for acknowledgement purposes. So HL7 ACK messages are consistently used across all the profiles. The transactions in the ACM profile take advantage of the IHE Rosetta terminology mapping, and that's based on the IEEE 11073 standards we talked about earlier. And that's to make sure we have consistent identifiers and nomenclature for the events we're processing through the systems. This leads to more predictable and interchangeable implementations of alerting environments out in the field. The transactions available in this profile can support phases in all aspects for alerting workflow processes from start to end, and all done via standardized method. So with many devices, such as physiological monitors or ventilators, waveform data can be included as part of the data they process out to these external systems. The Waveform Content module provides a standard method for inclusion of this data within both the prior mentioned DEC profile and the ACM profile as well. And this can be sent in two forms. A live streaming waveform can be provided that constantly updates to a receiving system, so you can have streaming capabilities, or content can be recorded into a waveform snippet for including in a snapshot of the patient waveform as the event occurred. And this can take place during an ongoing alert. The waveform snippet can be added as additional content within a PCD04 message from the AR actor going out to an AM, so it can be incorporated as part of alert, not a separate message. So using these two methods, remote monitoring the patient waveforms can be accomplished via workstations or alternatively via smart mobile devices. So speaking to the ACM working group a little bit more, the working group this year and PCD in general really are working on coordination with the Fire Structured Data Capture or SDC working group and the DPI program as well, among others, on the Quiet Hospital Initiative to address problems with audible signals and proper methods of notification. Research over the years has shown that device events from the patient's bedside can lead to too many audible alarm signals generated independently by devices in the room. As you can see here in the picture, there can be a great many of those, all making their own noises for their own purposes. And a good part of them is non-actionable or non-clinically relevant as well. So patients are subject to this, and it's a stressful noise level. It hinders their healing. Alert fatigue and delays in treatment can also be an effect that greatly affects the caregivers. So given the collaboration needed from multiple actors for a proper solution, the IHE was the right place for us to start this initiative. And given the history of cross-vendor and market-level collaboration, it's gone very well. Early research of this program by the working groups led to team-based efforts combining FHIR and HL7 2.x capabilities in the IHE standards to drive a quieter, more healing environment for patients and their families as well, along with better workflow and further diminishment of alert fatigue for the clinicians that are providing their care. Now, while it's known that much work has been done individually to address alert fatigue in the years since it was first recognized as a problem, cross-functional issues driven by limitations in data sharing and imperfect interoperability methods have left a big gap in the and it complicates the ability for us to truly respond and solve this problem. Now, this working group is applying the latest technology approaches to solve this problem at a whole new level in a collaborative fashion to ensure we're going to get adoption out in the field and ensure that it can work cross-functionally in this diverse healthcare environment. And solving that problem in a way that can predictably be designed and cost-effectively deployed by any institution as we start to see adoption happen. Input to this effort is coming from other organizations outside of the IHE. It's not just being done just inside.
Valuable input is being driven by provider organizations that are participating in the effort. The ECRI Institute is providing input. HIMSS, of course, as one of our parents, is helping us with information, and the FDA is helping to provide content and guidance to us on this as we proceed. With more potentially being added to the effort as we go forward, we've got other interested parties coming in all the time. This bodes well for the effort. Results of these efforts will be conveyed in virtual demonstrations for market feedback this year by some participating vendor organizations, and I'll cover that more later on in the annual updates. So just to summarize, there are now over 30 members from 10 different organizations participating in this initiative, including industry vendors and healthcare providers. Together, we're working to pursue the goals of this initiative, which include diminishing alert fatigue for staff and noise levels for patients, as we said, consolidating the audible alerting process in the patient's room down to a singular notice, and in the care unit itself as well, to diminish that noise or eliminate that noise eventually. Improving the workflow for responding to common non-critical alarms is important as well, and diminishing the number of touch requirements for those alarms, which is increasingly important in the age of COVID. We also want to increase the ability to address associated safety and satisfaction efforts through the technology improvements that we're doing, and these naturally are going to have effect on JCO requirements for healthcare institutions and HCAPs, considering the patient satisfaction items involved. So moving on, in the PCD program, we also look to improve safety of infusion order processing. Many people are aware of the 5 rights of medication administration. This is one of the recommended things to reduce medication errors and harm, and includes the right patient, the right medication, right dose, right time, and the right route for that medication delivery. With the infusion order processing using the point of care infusion verification profile, we also call PIV, a 6th right can be added to incorporate the process of these communications, and that's the right device being used to administer that medication. Information in this profile is passed for confirmation that the device is programmed correctly for the order. Standard message types are included in this profile to support transmission of the content from barcoding systems, BCMAs, along with standard communication methods for sending content up to the patient's health record. The benefits include, of course, better safety in the infusion process when associating the patient, and more complete record of that device association for records keeping or root cause analysis directly tied to the patient's record. So as the infusion is occurring, whether it was programmed manually or in an automated fashion through PIV, you need to get information on pause, resume, and other parameters that can be considered as a progress update into the patient's record, or at least into the device's record itself. These very commonly go to a bedside medication administration system, or alternatively, they can go directly to the EHR for viewing and validation purposes. For these transactions, we have a message type called a PCD03 in the infusion pump event communication profile, known as IPEC, to provide these types of messages for constant updates. Going deeper into our devices, we have IDCO. This is the implantable device cardiac observation profile. This profile handles updates of implantable devices such as a pacemaker or an implanted defibrillator. And these are done through gateways typically, right, that the patient will connect to at different times of the day. These gateway devices, which normally connect back to some corporate server or other capturing system, they capture raw data from the implanted device and then pass information via XML or some other proprietary format to the servers for those gateways, what they might be connecting to. Now, those gateways then process these updates out to the patient's record in the EHR, and this is done via the IDCO standard message. These messages, as you see them, are very similar to the deck profile message
that we discussed earlier. So it's a familiar format for the EHR to consume and makes it a little bit more standard. So moving on from the patient relationship focus onto the connected devices that are supporting them, we have our last profile for the day. The medical equipment management profile, or MEM as we call it. MEM covers two areas, including device management communication, or DMC, and location services. MEM is focused on the management of the healthcare devices we're using for care of our patients, so really focusing on the healthcare of those devices. These profiles produce information on device status, like is it charging, the charge level of the device, device location or device availability is also covered, such as, is the device assigned to someone? Is the device available and ready to be assigned to somebody? And combining data elements from these profiles, we can consistently automate answers for some common questions, like where can I find an available device? What's the idle rate for my devices? How much utilization am I having of my devices in my organization? Do I need more inventory, or do I have a surplus of devices? This is particularly important with vents right now. Is the pump leaving the building? If I have an ambulatory device, is that a theft? Perhaps I should get a notification based on the location of that device. Availability of these data points that I just discussed to drive clinical efficiencies. It allows for staff to quickly find the devices they need for patients on a busy floor, and management of loss prevention is naturally an important effect of this as well. With MEMLS in use at any facility, acute location can be added to an ongoing ACM process. So in an ACM alert for devices that are actively monitoring, we can include the notification. They can be notified, which provides us with the location of the device where it currently is right now. And this can be put into a PCD04 message as part of the original notification going out to an AM actor from an AR. This profile drives a better understanding of asset management needs for the facility and provides a pathway to standards-based alerting of conditions for devices that are ambulatory. So after looking at the profiles and actors, let's shift attention to some of the supportive tools used by the PCD program and the devices domain really as a whole. Having all of these profiles really wouldn't do much good or be useful without some assurance that they can be independently verified in their capabilities. The National Institute of Standards and Technology, or NIST, partners with the IHE, and they create independent testing tools for us that allows us to verify proper operations and conformance of vendor-created solutions that use these profiles. These automated tools are available online for implementers to test their conformance to the IHE profiles and ensure partner or vendors can work with them in live implementations. These tools are also used to verify vendors during virtual testing for fall pre-connectathons, prior events, and then for our in-person events that we have in January, the IHE Connectathon in January. The message the PCD vendors produce and consume can be put into tools, and we can see here a general path for the automated validation process as a system is tested. A report is generated for each test case, which can be copied by the test user for later use. Each vendor can have a login to the test environment, and the testing information can be stored for later consumption as well. Now, this allows for information to be used later to improve the tools by the domains themselves or by the individual, and also for improvement of the profiles as we look at Connectathon results, as we look at the features of the testing that's occurred. We take a lot of information away from that and use it to augment or improve the profiles to make them better. So for interested parties looking to develop against the profiles, these tools are free and they're open for testing. They can be accessed online or deployed on a local network for localized conformance testing in your organization. it's kind of hard to get out sometime and do testing from our corporate firewalls. So that's important to have. And that's designed so we can fit anybody's organizational needs. They're easy to use set of tools for new implementers to confirm they're conformant with the IHE profiles prior to live testing with other vendors or participation in those sanctioned IHE testing events we talked about on the last slide. So next up is an activity update. As part of the annual presentations, we also like to provide updates on planned activities for the year. Each year, the domain has particular efforts we pursue that help further and promote the profiles. These efforts open up the opportunity for new profiles in some cases as well, as we get input from provider organizations or new vendors coming into the picture. And they also constantly improve the available profiles as more vendors or healthcare systems use them and provide input after they originally develop. So looking at some of our program activities for this year, something that we always have on the list is increasing interactions with end user communities and provider organizations. We are always looking for feedback, and the more the better, to make sure that we're having a well-rounded look at the need for conformance of these profiles in the market. Coronavirus impacts are driving increased interest in remote patient monitoring, both at home and in the hospital. The devices domain is well positioned to develop and promote interoperability, which is essential to the rapidly deploying these solutions on a global scale that can have effect in these areas. So that's a concentration for us this year as well. Quiet Hospital, of course, that's going to continue on what we discussed earlier. The PCD program and ACM in particular are going to continue to partner with the Fire SDC working group on that initiative. Results of those efforts are going to be conveyed in demonstrations. As we talked about earlier, HIMSS 2021 is a target there for the showcase, as we would typically do. But we also have some forthcoming video demonstrations being done by some IHE member organizations that are in production now and are going to be coming forth very soon. So keep an eye out for those. Multiple programs in our domain continue to have representation in the IEEE P1847 working group. In the IEEE, this group works on standards for location services in healthcare, and they're going to be making use of some of the work done by the PCD working groups, MEM in particular, to enhance those profiles. The domain continues to work to include PCD profile items into the IEEE standards documentation for common nomenclature across the systems, and we expect that work to continue this year also. Some additional MEM activities to expand. MEM is a relatively young profile, so we've got a lot of activity there. We're extending MEMDMC to include remote command and control of devices in a device agnostic or generic manner, including speaking to safety and security issues as we're going through that process. To gain expert input on that, we're actively promoting the use of MEMDMC, talked about earlier, to computerized maintenance management systems, or CMMS as they're known in the market. And we're looking for more people to participate in that now. We're also looking to promote MEMLS, the location services side of things, to additional real-time location services vendors. MEM is a relatively young profile, as we said, but we already have 3 RTLS vendors now participating in that with the intent to grow it over the coming year. And we do have some interest there, looking for more. Finally, work is going to continue this year that we've already started within the PCD profiles, some of the profiles anyway, to support fire resources via work being done by the Devices on Fire working group. Some work has already been done there to translate the deck profile, and more work is being done planned for this year between the PCD program and the HL7 fire working groups. So any standard wouldn't really be a standard without participation and contributions from the vendors that provide the products to the market and the providers that use them. We're looking constantly to expand participation in the IHE standards from market vendors to drive them to be more useful and continuously improve the way healthcare communication is handled For healthcare vendors looking to participate, the actual effort is really small. It's small in scope, but it can be extremely beneficial once they've applied it. And here, this is a list displayed here of what we ask our committee members to go through. And becoming an IHE member, participating in the PCD efforts provides the chance to bring new solutions to the table for preview, plus review, participate, and vote on changes that are coming to the profiles to have a direct effect on them. As members, we're all evangelists of the IHE standards, driving support for the standards within our individual organizations and also encouraging new vendors to join the effort and provider organizations. Participating in the testing events and promotion of integration statements that we all produce to our mutual customers and to our partners drives confidence in the interoperability across these vendors for the folks who are going to be implementing these profiles at their sites. To that effect, new vendors and provider organizations join us each year to provide valuable contributions. The opportunity to participate in the demonstration events we talked about, Connectathon most notably, shows other organizations how the standards make a difference in cooperative and realistic healthcare environments or scenarios. And it's not just about the device vendors, it's also about the users or the provider organizations are going to be delivering these standards or consuming them, I should say. At the IHE, we promote participation in the committees from a healthcare organization's perspective as well. Many of the activities are the same for a consumer as they are for one of the vendors that are participating in the profiles. Organizations participating in the IHE have the ability to see new capabilities or value coming down the road, which can drive more efficient and cost-effective deployment of the solutions they're looking to incorporate into their enterprise. And these organizations also have the benefit of input into the design of the profiles, and that's going to ensure strategic fit for the healthcare institutions now and going into the future. Input from the consumers of the IHE profiles represents some of the most important information that we can get to drive these standards going into the future as well. So we're always looking for more organizations. So if you think you'd be interested, please reach out to one of us and we'd be happy to help. So finally, we have here a few links for helpful information. This can help organizations in decisions, design, and validation for new adopters that are coming into the profiles. The PCD profile maintains a listing of commercially available systems and supportive systems which have passed annual IHE Connectathons. These are adoptive of PCD profiles for conformance. The list of cooperatively maintained IHE PCD contributing vendors with comments and input from end users is there. There's an ever-changing list of these vendors. We see updates to this on a quarterly basis, and that's all presented here in its entirety. It's big, so we can't present that list online, but it is available at the links that we've provided. Some other helpful links to remember are the links to the PCD website and our wiki, which hold information and resources for developers and for users. Also listed here are the co-chair contacts on those two links, and they can be very helpful, myself among them, for planning your journey into the IHE for adoption. And those lists incorporate technical as well as planning representatives for our committees. The links to the NIST testing tools and the Rosetta terminology for standards, codes, and nomenclature are also here, and those are publicly available to assist implementers with conformance and a highly valuable tool early on in your adoption process. So that reaches us to the end of the presentation. I wanted to thank everybody for participating today. Please reach out for questions or guidance on how to join. And for any of our recent adopters, if you have questions, please reach out to one of the co-chairs and we'd be happy to help you. Thank you very much, everybody, and have a great day.